Good morning. First, I want to thank the organizers for their kind invitation to take part in ECR. Oh, that's not running.
Okay.
Thank you. In the next few minutes, I am going to talk about percutaneous drainage of thoracic fluid collections. I have divided the presentation by the different fluid collections that you can find inside the thorax. First, we're going to talk about pleural drainage, and then we'll discuss the drainage of lung abscesses, the mediastinal collections, and pericardial effusions. Pleural infection was first described in medical texts of ancient Greece. In our day, about 2 million people are affected by parapneumonic effusion. The presence of a pleural effusion associated with lung infection increases morbidity and mortality rates, with a mortality rate of 20% if untreated. What is the current management of a pleural effusion? Current guidelines do recommend the sampling of parapneumonic effusions with a thickness greater than 10 millimeters. Although you have to know that pH can vary depending on the place that you take the sample. Here you have a case of a patient with an esophagectomy who developed a right pleural effusion. Then we performed chest ultrasound and found 3 types of fluid: non-complex, septated, and complex septated. After that, we performed an ultrasound-guided thoracentesis and found these results. Note that the pH levels were extremely different in each of them. The ACCP guidelines published in 2000 showed that a large effusion, a loculated effusion, or effusion with thickened pleura should be drained. Also, a pleural effusion with positive culture and gram stain or a pH below 7.20 should be drained. Obviously, a purulent pleural effusion has to be drained. And when do we have to use a large or a small bore tubes? The indications for small bore tubes are the same as for large bore tubes. Now the British Thoracic Society guidelines do recommend the use of small bore tubes, with only one exception, that is acute hemothorax. In this setting, the viscosity of the blood and the velocity of the production of the effusion prevent us from using a small bore catheter. Globally, small bore tubes have fewer complications than large bore tubes. The main complication of both kinds of tubes are pneumothorax and hemothorax. It is published that small bore tubes are less painful than large bore ones, but there is no data supporting this idea. The main complication of large bore tubes is malposition that can be about 30 or 50% of the cases. If you insert a small bore catheter using the Seldinger technique, there is no problem of malposition. The effectiveness of the different kind of tubes depends on the indication. The best results with the small bore tubes are in cases of pneumothorax or malignant pleural effusion. The best results with large bore tubes are in cases of hemothorax and empyema. It is published that small bore catheters inserted with radiological guidance have an additional cost. But the cost of large bore tubes is increased in cases of malposition. The message that we can take from this is that correct positioning of the chest tube is more important than size. The main cause of failure of successful drainage with a small bore tube is due to the presence of loculations. And you can resolve this by insertion additional small bore tube in the remaining locules. This is an example of a patient with an empyema treated with a large bore tube with a poor outcome. There were 2 loculations, one posterior and another lateral, and we inserted 2 different drainages in each of them using ultrasound guidance, as you can see here in these images. In cases of pleural effusion, I prefer to use ultrasound guidance. Ultrasound is able to predict the outcome of the drainage. A pleural effusion with internal septa presents a worsened response to percutaneous drainage and a worsened prognosis with increased admission to ICU and increased mortality. The success of the drainage is related to the ultrasound features. Anechoic pleural effusions have a success rate of 92%, complex non-septated 81%, and complex septated 62%. The message that we can take from this is that the pleural effusion should be drained immediately before ultrasound features become worse. And when do we have to use CT or ultrasound guidance? Ultrasound allows a real-time monitoring of the procedure, and this is only possible with CT when using fluoro-CT. In cases of hydropneumothorax, CT guidance is preferred because during all the procedure, is it possible to see the wire and the catheter inside the pleural effusion. In cases of loculated effusion, some authors prefer to use CT guidance, but in our experience, it is possible to do with ultrasound guidance. Ultrasound allows any approach, but CT is limited to the axial plane, but you can change this plane by moving the angle of the gantry. Finally, ultrasound can help in the follow-up of these patients, and CT can be useful in cases of complex collections not responding to drainage. You can choose catheters from 6 to 14 French, and ultrasound guidance is recommended, but you can use CT in cases of hydropneumothorax or collections in the mediastinal pleura. You have to insert as many catheters as required, depending on the number of loculations. Once the catheter is inside the pleural space, you have to start draining during the tube insertion in the same room and connect the tube to an underwater seal with negative pressure. Here you have an example of a pleural drainage. Here you can see the needle next to the pleura and how we can administer the anesthetic. Then, using the same approach, we introduce the needle inside the pleural space. Always using ultrasound guidance, we insert the wire, trying to put in the posterior and inferior aspect of the pleural space. In this image, you can see here the small bore catheter inside the pleural space. In this moment, we had started to drain the pleural effusion, and you can see here the re-expansion of the atelectatic lung. Fibrinolysis is not recommended for all patients. There are no clear data about when to use and who will benefit with the use of fibrinolytic agents. There are some options described in literature, but the best results are obtained with the use of TPA and DNS that improve radiological appearance, decrease surgical referral, and reduce hospital stay. In cases of malignant pleural effusion, similar success rate is described using large and small bore catheters. But the small ones have minor patient discomfort, are easily placed, and have a comparable outcome. The complications are the same as for the drainage of a parapneumonic effusion. Only in cases of drainage of a malignant pleural effusion, you should be aware of development of seeding. Seeding is uncommon in non-mesothelioma malignant effusions. In cases of mesothelioma, you have to perform prophylactic radiotherapy to the site of the chest tube insertion. In patients with transudative pleural effusions, a chest tube added to the therapy to the underlying systemic disease can help to liberate from mechanical ventilatory support, in decreasing pulmonary artery pressure and pulmonary arteriovenous shunt, and increasing oxygen delivery and consumption. In this setting, it is recommended to use small bore tubes with ultrasound guidance. Now we are going to talk about lung abscess drainage. The main indications are the persistence of the abscess after 10 or 14 days of medical therapy, in patients with no response to antibiotics, and abscesses greater than 4 centimeters. Obviously, in septic patients, there has to be no delay. You can use ultrasound or CT for guidance, depending on the location of the abscess, as a pleural abscess can be drained with ultrasound guidance, but abscesses surrounded by lung only should be drained with CT guidance. You have to use the Seldinger technique and a range of catheters from 6 to 12 French. Once the catheter is in place and the abscess is evacuated, you have to perform daily irrigation with normal saline. The role of fibrinolytic agents in the lung abscess drainage is unknown. The reported efficacy of percutaneous lung abscess drainage is about 84%. The complications are described in 16%, and the mortality rate is 4%. The main complications are clogging, pneumothorax, hemothorax, and hemoptysis. You can prevent pneumothorax by avoiding the puncture of normal lung. You should distinguish between lung abscess and necrotizing pneumonia, because the drainage of a necrotizing pneumonia can cause a bronchopleural fistula. The drainage should not be removed until reduction in abscess size with cessation of purulent drainage for at least 3 days and absence of clinical signs of sepsis. This is an example of a patient with an abscess in the left upper lobe with no response to medical therapy. We inserted a 10 French catheter inside the abscess, as you can see here in the image. And this is the chest X-ray performed 2 months later, showing only a residual scar. This was a young man who, after thoracic surgery, developed a lung abscess. Due to the position, we inserted an 8 French catheter using CT guidance, and after 5 days of treatment, there was complete resolution of the collection, as you can see in these images. In some cases, like in this elderly woman with an abscess inside a pneumonia, aspiration of the collection is as effective as the drainage, and it is well tolerated. Now we are going to talk about mediastinal drainage. There are few cases published in the literature. The main indications are the drainage of pancreatic pseudocyst and esophageal anastomotic leaks. CT guidance is preferred, but you have to know that usually you will have to use contrast agents to distinguish mediastinal structures. This is a case of a patient with an esophagectomy and pleural and mediastinal collections. Using ultrasound guidance, we drained both collections and demonstrated that the mediastinal collection was a chyloma due to sectioning of the thoracic duct. This other case was a patient with a small abscess in the mediastinum after a spontaneous esophageal rupture. Using CT guidance and the Seldinger technique, we put a catheter inside the abscess, as you can see here in these images, using a transpleural approach. Finally, we are going to talk about pericardial drainage. The main indications are pericardial tamponade, suspected malignancy, empyema, and tuberculosis. The main complications are arrhythmias and pneumomediastinum. When you perform this procedure, you have to monitor the patient with ECG, and in the case of development of an arrhythmia, the catheter should be removed. The approach should be selected according to the distribution of the pericardial effusion in ultrasound. This is an example of a pericardial drainage using a subxiphoid approach and with the correct positioning of the tube in the posterior aspect of the pericardium, as you can see here in this image. In this case, there was suspicion of a malignant or a tuberculous pericardial effusion. Using ultrasound guidance, we inserted a drainage trying to put it in the posterior aspect of the pericardium. Pericardial tamponade depends on the evolution time, and rapid small effusions can cause pericardial tamponade, as you can see here in this example. This patient, after a bypass surgery, developed a rapid pericardial effusion. Due to the small approach, we inserted drainage using CT guidance and crossing an intercostal space. In conclusion, percutaneous drainage of thoracic fluid collections is a good alternative to surgical treatment. Radiologists should know indications, technique, and complications of the procedures. Ultrasound and CT can be used for guidance, but in my opinion, ultrasound had to be the technique of choice, and CT may be reserved for collections that are not visible with ultrasound. Thank you very much for your attention.